Chapter 22, Neurologic Disorders. Let's talk about headache first because this is the most common type of pain when we're talking about neurologic system. There could be a lot of causes for headaches, and these are the types of headaches. You have migraine, cluster headache, tension headache, and headache that are related to disorders of the eyes, teeth, or sinuses. Migraine headache, this one is resulting from the intracranial constriction, vasoconstriction followed by the vasodilation. Cause is unknown. There is no single cause that is known for migraine, but the most important to remember is there will always be a trigger. Okay? Trigger. There will always be a trigger for migraine. What are those triggers? It could be hormonal changes, maybe when it's time for menstruation or ovulation, food containing nitrites, caffeine, strong odors, bright lights, changes in weather, skipping meals, head trauma, artificial sweeteners, alcohol, and stress. Okay, so what are signs and symptoms of your migraine? Obviously, they're going to have that headache, and then they're going to experience like irritability, vision disturbances. They may even have those nausea and vomiting. So usually the pain is like unilateral, like they would just feel it first in one side of their head, and usually begins in the temple or in the eye area, and then it will become very intense. And then the patient will have those what we call hypersensitivity to light, where that's why if you have patient that's actually suffering migraines, one thing that helped them is actually sitting in a room, in a quiet room, very less stimulus, and then the light is actually off because they are actually hypersensitive to light and sounds. Treatment for migraine headache. If it's mild, then we can actually use acetaminophen or aspirin. If it's more severe and the acetaminophen and the aspirin is actually not working, then we can actually help the patient and give them this medication ergotamine, which is your Cafergo, or your sumatriptan or Imetrix. These medications are either tablet or injection. Sometimes also the clinician will prescribe the patient some calcium channel blockers or beta blockers, because remember that migraine is actually resulting from intracranial vasoconstriction followed by vasodilation. So those beta blockers and the calcium channel blockers actually can help with those vascular changes. If it's severe or chronic, rather, we use this medication on botulinum toxin A or Botox. These are for those patients that actually having those chronic migraine headache and actually having those severe ones that last for very long time, sometimes even days. This actually will help them. But please remember that even though we don't know the cause for migraine headache, we discussed that there will always be a trigger. So emphasize prevention of those triggers. For example, what is triggering the migraine headache of your patient? Is it stress, right? So help them um, think of some ways to lessen the stress, maybe avoid whatever it is that's causing them stress? Is it food that is actually causing the or triggering the migraine headache? Then avoid eating those foods. And by the way, the book actually gave us some examples of triggering agents, triggering foods. It's in page 369. Some triggering agents are chocolate, yogurt, aged meat, cheeses, alcohol, red wine. And again, if they can avoid it, then it will help controlling this migraine headache. Cluster headache. This one is called cluster because it occurs in series of episodes followed by a long period with no symptoms. This headache is actually intensely painful and seem to be related to stress or anxiety. The difference between the migraine headache and the cluster headache is that with migraine, there will be a trigger. There will be warning symptoms. With your cluster headache, there's no warning symptoms. They are shorter in duration compared to the migraine headaches and usually respond well with treatment like cold application, this medication, indomethacin, and your tricyclic antidepressants. Tension headache. This one results from a prolonged muscle contraction associated with anxiety, stress, or stimuli from other sources such as a brain tumor or an abscess tooth. Where's the location for the tension headache? It actually varies. Location of the pain may vary. The patient may experience nausea and vomiting and dizziness and the ringing of the ear, the tinnitus. Headaches, this headache may persist for days or even years. Treatments for this depends what is actually causing it. Like we said, if it's anxiety or if it's stress that's actually causing the tension headache, so do something to actually correct the situation to prevent it to prevent the tension headache. But going back to the treatment, psychotherapy can help because if you actually take care of the anxiety and the stress, then it can help with the tension headache. Massage, heat application, relaxation techniques, analgesics, and anti-anxiety can help. Seizure disorders. So seizure disorder involves a large number of hyperactive neurons that use excessive oxygen and glucose in the brain. This, the brain is actually involved in a highly chaotic pattern that yields abnormal activity and behavior. So, what are possible causes? You have trauma or infection, reduced cerebral perfusion, just like when we did talk about your increased intracranial pressure or your ICP, electrolyte disturbances, poisoning, tumors, and maybe even genetics. How do we diagnose? Medical diagnosis depends on the signs and symptoms of the patient. And usually what they're gonna do is maybe the patient or the family member of the patient is going to report like seizure-like activity. So that starts, the diagnosing process. And then what we're gonna do is the patient will have this EEG or your electroencephalography tracing that we did talk about when we did chapter 21. This is where they will put those electrodes in the scalp and then it's going to read the electrical impulse of the brain. So obviously if there's an abnormal tracing or abnormal brain activity, then they could diagnose a patient in addition to the um, other manifestations of the seizure, then they will diagnose the patient with a seizure disorder. Seizure classification. So you have two classification. You have your partial, which involves only a specific area of the brain, and you have the generalized seizure. Generalized involves the brain, the whole brain. Okay. Um, for your partial, seizure, it is further subdivided into simple and complex. Simple and complex. But what are the difference between the two? Simple seizures affect part or one cerebral hemisphere, and consciousness is not impaired. Okay, that's for simple partial seizures. Now, if we're talking about complex seizure, then this one actually involves an impaired consciousness. The consciousness is going to be impaired, and the patient may exhibit bizarre or repetitive behavior. Um, Aura is something that actually the patient will feel, or it's a sensation right before they are going to have that seizure. For example, maybe it's like dizziness or numbness, visual or hearing disturbances, maybe some odor. Sometimes patient will actually um, report some like perception of an offensive odor, and sometimes even pain. They will even have like visual or hearing disturbance, so they will feel it, they will feel the sensation, and this is actually involves with um, the pre-phase or before a seizure actually happens. So here you go, your seizure classification. You have a partial seizure, also called as the focal seizure, and localized to a specific area of the brain, and it's subdivided into simple or complex. And then your generalized seizure involves the entire brain, and there's going to be a loss of consciousness. Okay. And then also we have unclassified seizure, those that are not readily classified under a partial or a generalized, then they put it as unclassified seizures. So generalized seizure, this is what we call tonic-clonic seizure, or also called as the grand mal seizure. If you want to see it, it's in page 371. This figure 22.1 is showing us the phases of a grand mal seizure. You have your tonic phase, clonic phase, and the postictal phase. So for the first one, the tonic phase, this is marked by a loss of consciousness. The patient is gonna lose their consciousness. They might even fall. They will fall to the ground. They will start crying, and then they will have the generalized stiffness. Sometimes incontinence actually may occur. And then after the tonic phase, you're going to have the clonic phase, which is going to be the jerking of the extremities, jerking of the limbs. And then there will be like a frothing. The saliva will actually come out from the mouth of the patient. All right, then you have the post-tictal phase. What is post-tictal phase? This is after the seizure. The seizure activity has ceased. The patient is usually sleepy around this time, very tired, drowsy, and they might not even remember memory of that seizure. Some more classification of your generalized seizure. You have absence, or what we call your petit mal. This one is a brief periods of loss of consciousness in which the person is actually appearing like they're daydreaming. Okay. And then you have myoclonic, which is the brief jerking or stiffening. And then you have atonic seizure, which is formerly called drop attacks. because this is a sudden loss of a muscle tone that causes the patient to actually collapse to the floor. Okay, status epilepticus. Status epilepticus is a medical emergency because this is a prolonged seizure activity. So status epilepticus is actually maybe one seizure that actually extended for a long period of time, and then, or like a continuous seizure, or a repeated seizure in a 30 minutes interval. So really long. What happens is that the prolonged seizure activity is going to decrease the perfusion in the brain. When that happens, it depletes the brain, the oxygen and the glucose that it needs, and it can actually cause a permanent brain damage. So that's why status epilepticus really is a medical emergency. Care of a patient with a seizure disorder, so we can give them the anticonvulsants or anti-epileptics. So let's turn to page 372 to 374. I need you guys to actually be highlighting things in here in this box table 22.1 for us to actually remember and go back to and read about it. So first off, anticonvulsants, very common is your phenytoin or your dilantin. Two things to remember here. Side effects actually, well, the first two major things that we need to remember is to give this medication with food. Give drug with food to reduce GI irritation, and there is a high risk for gingival overgrowth. So what we're going to do is we're going to provide the patient with meticulous mouth care to prevent this gingival overgrowth. Phenytoin has some unusual side effects, including aplastic anemia and agranulocytosis. So those are things that we're actually monitoring. And then you have phenobarbital or luminol. This one is also common. Side effects that we want to highlight is the drowsiness and the respiratory depression, nausea, vomiting, diarrhea, constipation, rash, photosensitivity, and muscle aches. All right, and then you have your carbamazepine, which is your Tegretol. What do we need to remember here under the side effects? Please remember, it can cause drowsiness, ataxia, blurred vision, BP increase or decrease, heart rate, urinary retention, rash, hepatitis, aplastic anemia, and agranulocytosis. Okay. And then you have lorazepam or your Ativan. This one is used for initial treatment of a status epilepticus. Okay, let's stop here a little bit. So you have a patient that actually has a seizure disorder and then started having this status epilepticus. We did mention status epilepticus is the prolonged seizure, and it's not good for the brain flow to the for the blood flow to the brain, right? So what you can use is actually a lorazepam or your Ativan. This actually will help, calming down those seizure activity. However, there's a problem with this medication because one of the side effects is actually physical dependence. Okay, you can start giving the Ativan to the patient, but there's a high risk for dependence, physical dependence. Um, we have to remember that this Ativan or the lorazepam is actually going to cause the patient to be drowsy. So you make sure that there's going to be a safety precaution for the drowsiness. Valproic acid or Depakote is another anticonvulsant. And what we do for this patient is we actually monitor the blood work and see if the patient is actually having the therapeutic um, dose, or not therapeutic dose, therapeutic effect from the medication. Um, And then you have gabapentin or neurontin, which is an anti-epileptic drugs. One side effect that we would want to highlight is your somnolence, okay? And because of this, you make sure that there's going to be a safety precaution that is in place for the patient. You have pregabalin or your Lyrica. Please remember or highlight under side effects: somnolence, ataxia, diplopia, arthralgia, and thrombocytopenia, where the platelets is actually going down. The pyramid or your Topamax. One side effect is your somnolence. And then on the next page, you have your oxcarbazepine or your Trilepto. And then you have your Keppra, which have side effects of somnolence, dizziness, impaired coordination, abnormal behavior, fatigue, and infection. So if your patient is actually taking this medication and you see that the side effects are somnolence or dizziness, we make sure part of your nursing intervention is to make sure that the patient is actually safe. There will be a safety precautions for the patient. Okay, now let's talk about the seizure precautions. What are the things that is actually a part of your seizure precaution? If you have a patient that just, had a dropped attack and then is having a seizure on the floor, the first thing that you need to prioritize is actually to protect the head. Cradle the head. Make sure that the head is protected, okay? That's one seizure precaution. Turn them to their side, making sure that they're not aspirating in their own saliva. Do not put anything on the mouth. All right, do not put anything on the mouth. I know that long time ago, when there was someone that is actually having a seizure, before, what they do is like they put something in there because they think that it will damage the tongue when they're clenching their jaw or having the seizure. Now please do not put anything on the mouth. Management of the seizure, your do's and don'ts. Let's see, it's box 22.1 in page 374. So do's: do remove any objects that could cause harm. So yes, please make sure that the environment is actually the patient is actually safe in the environment, okay, with the environment. Do turn the position to one side if possible. Do note the time the seizure began and how it progressed, because remember, if it's a prolonged, then it's not good. It's called a status epilepticus, and it's not good for the perfusion in the brain. Do assess and document postictal, which is the after the seizure status. Do allow the person to rest quietly. Do call a medical emergency if a generalized tonic-clonic seizure lasts more than 4 minutes, or if seizures occur in rapid succession. All right, do not restrain the person unless he or she is in a grave danger or severe injury. Do not attempt to force anything between the person's teeth. Okay, types of head injury. You have scalp injury, concussion, contusion, hematoma, intercerebral hemorrhage, and penetrating injuries. Scalp injury, these are your lacerations, contusions, abrasions, or even a hematoma. Obviously, it's an injury, so the patient may bleed profusely. So we need to address this right away. Concussion. Concussion is a head trauma in which no visible injury exits to the skull or the brain. The patient has a loss of consciousness lasting less than 5 minutes and may have a headache, amnesia about the event, nausea, and vomiting. A contusion is a more serious situation than a concussion because actual bruising and bleeding exists in the brain tissue. Contusions can be very serious, especially if the brain stem is affected, because remember, what is the brain stem responsible for? Your vital functions, your respiratory center. Okay, so contusion, very serious. It's more serious than the concussion, and your goal is to actually making sure that the brain stem is not affected, or preventing it from affecting the brain stem, because otherwise, if the respiratory center is actually affected, how is that patient going to breathe? Patient is going to die. All right, hematoma. Hematoma, you have a subdural and you have intra you have epidural hematoma and subdural hematoma and intracerebral hemorrhage. Okay, so for hematoma, this one is actually resulting from tearing of the veins that drain the brain, allowing blood to accumulate in the space between the dura. So you're gonna have subdural hematomas. You have acute, subacute, and chronic. Depends on the time of the manifestations. So acute subdural hematomas develop within 24 hours of the injury. Subacute subdural hematomas are seen more than 24 hours and is less than 1 week. Chronic subdural hematomas occur within weeks or even months of the original injury and are associated with low impact injuries that cause very slow, profuse, or diffuse bleeding. All right, and then you have intercerebral hemorrhage, which is obviously the hemorrhage inside the brain. Epidural hematoma, this one forms in the space between the inner surface of the skull and the outermost meningeal covering of the brain, which is called the dura. Okay, we did talk about this, your subdural hematoma and your epidural hematoma. Subdural actually depends on the time. Acute is within 24 hours. Subacute is more than 24 hours and less than a week. Chronic is within weeks or even months. And then epidural, this one forms in the space between the inner surface of the skull and the dura. Surgical treatment. Surgical treatment really depends on the type of trauma um, that we're dealing with, okay? Uh, if it needs surgical treatment, like, removing or evacuating the hematoma, then that's one thing. Nursing care for patient that has a head injury. Monitoring signs and symptoms of your increased ICP. And again, the early stage that you're going to see when you're looking for increased ICP is the altered level of consciousness. Okay, always the altered level of consciousness when you're talking about neuro. Positioning, fluid balance, preventing infection, and rehabilitation. Brain tumors. So brain tumors, not all brain tumors are malignant. Some tumors, they could be benign. What are the causes and risk factors? Causes really is generally unknown, but some appear to be congenital in origin, whereas others may be related to hereditary. Also, environmental factors. This actually plays a role in the development of some brain tumors. Signs and symptoms. Well, it really depends on where the brain tumor are, or what are the part of the brain that is actually affected or invaded by the tumor. It could be maybe a motor or sensory symptoms, even visual disturbances, and headache. They may be a manifestation for tumors. So nursing care, we try to make sure that the patient is very comfortable. We address pain, management of pain, um, impaired cognition, potential injury, impaired mobility, and inadequate coping. Infectious and inflammatory conditions. You have meningitis, encephalitis, Guillain-Barré syndrome, Parkinson's disease, multiple sclerosis, ALS, or your amyotrophic lateral sclerosis, Huntington disease, myasthenia gravis, trigeminal neuralgia, neurofibromatosis types 1 and 2, Bell's palsy, cerebral palsy, or post-polio syndrome. Meningitis is the inflammation of the meningeal covering of the brain. This is usually caused by many organisms, but some of them could be bacterial infection like your Neisseria meningitis or Streptococcus pneumoniae and your Haemophilus influenzae. Signs and symptoms, you might have that headache, the nuchal rigidity or the stiffness of the back of the neck, irritability, decreased or diminished level of consciousness, photophobia, hypersensitivity, and then seizure activity, positive Koenig sign or positive Brzezinski sign. If you want to see it, it's in page 379. Letter A is actually Koenig sign, and letter B is actually your Brzezinski sign. Positive Koenig sign is when the patient's leg is actually flexed as shown. The patient is unable to completely extend the leg. Okay, and then for your Brzezinski, this is when the patient initially will lay flat and then the nurse will flex the patient's neck. When she does that, the patient's hip is actually going to flex too. And these two signs are actually manifestations or signs and symptoms that you will see when there is actually an inflammation of the covering of the brain, which is your meningitis. So how do we diagnose meningitis? Lumbar puncture. We did talk about lumbar puncture. It's when they will stick that needle and then we'll collect the CSF and they're going to see if there's actually some inflammation that is going on in the brain. With your meningitis, the CSF, instead of being colorless and clear, it will appear milky and purulent. Medical treatment really depends on what is actually the causative organism. But if it's a bacteria, obviously we can treat this with antimicrobial or your antibiotic. But if it's a viral, then we cannot give them medications. No specific drugs will be effective. We will just make sure that we're addressing the symptoms or our symptomatic treatment. We might even give some anticonvulsants to control seizure activity if necessary. When we're taking care of patient with meningitis, so we gotta make sure that we are actually taking care, making sure that there's always going to be a cerebral or a good cerebral tissue perfusion, which is the blood flow to the brain, making sure that the patient is actually oxygenated properly. Pain is controlled and there's no further potential injury, especially because meningitis, they have a risk for seizure. So you would put that patient in seizure precaution. Fluid volume deficit, we have to prevent that, and then potential complications of immobility, making sure your patient is actually being turned in reposition, air mattress, or whatever it is that you could put as intervention to prevent complications of the immobility. Encephalitis is inflammation of the brain tissue itself. These are the signs and symptoms. If you look at it, some of them are actually the same as your meningitis. We have fever, nuchal rigidity, headache, confusion, delirium, agitation, restlessness, comatose, aphasia, hemiparesis, facial weakness. Treatment care for the patient with encephalitis. They are focused on comfort and increasing the strength and putting the patient, making sure that the patient is actually on seizure precaution because there's a high risk for seizure. So making sure that the patient is safe. So we will put them on a seizure precaution. Guillain-Barré syndrome is an autoimmune response that destroys the myelin sheath around the peripheral nerves. So if you remember that the um, neuron is the one that's actually responsible for the electrical impulse, from one neuron to the next neuron. And myelin sheath, the one that covers the neuron, is the one that's actually speeding up that electrical impulse and making sure that there's a smooth transfer of that electrical impulse from one neuron to another. So if that is the one that's actually being destroyed in the myelin sheath, and then the impulse or the transfer of the impulse from one neuron to another, then there will be some problem. Cause is unknown, but usually the patient will report a recent viral infection or vaccination secondary to a viral infection or vaccination. What happens is that after the patient actually have a recent viral infection, the patient is going to have the signs and symptoms of the Guillain-Barré syndrome. We also call this acute inflammatory polyneuropathy. And then what are those effects on autonomic nervous system for these disorders? There will be hypertension, orthostatic hypotension, cardiac dysrhythmia, profuse sweating, paralytic ileus, and your urinary retention. So for your Guillain-Barré syndrome, you have three phases. You have the initial, you have the plateau, and then the recovery. If you want to see it, it's in page 381 of the book, table 22.2. Very helpful. We can read through this. In the initial, this one is usually 1 to 3 weeks and ends when the disease ceases to progress. This one begins with onset of the symptoms. And then for the plateau, this is when there's no further changes. This could last from several days to 2 weeks, and then you're gonna have your recovery, which is going to be a gradual improvement and maybe as long as 2 years. And unfortunately, some residual effects may be permanent. So how do we diagnose Guillain-Barré syndrome? We diagnose it with the use of lumbar puncture. We discussed this from the previous chapter. This is where a needle is going to be inserted on the back of the patient to collect the CSF, and then we're going to make sure that there's no elevated protein in the CSF. Otherwise, if there is an elevated protein in CSF, it could suggest Guillain-Barré. Medical treatment. How do we manage this disorder? Is to preserving vital functions. Again, this is the fluctuating disorders, right? So you're gonna have that initial phase where the patient is going to be sick, plateau, and then it's going to recover, and then years after, we're gonna go back to the initial phase again. Okay, so when you're dealing with that, then what you want is to just preserve vital functions. We can also give some corticosteroids, which is an anti-inflammatory, and we can do plasmapheresis. What is plasmapheresis? Plasmapheresis is a process in which we remove the blood, we centrifuge it, and then we return it to the patient. What it does is it's actually trying to like filter those antibodies that is triggering the autoimmune disease it's being removed from the body by a machine, and then it's like a filtration system of the blood. So what are the nursing care for the Guillain-Barré syndrome? Where number one is monitoring respiratory status, okay? Because this is a disease that is actually advancing and progressing. So if it progress or reach that part of the body that's actually responsible for the respiratory, like your diaphragm or anything on the chest, then it's going to be a bigger problem. So we want to make sure that we're monitoring the respiratory status of the patient. You can give them antidysrhythmic drugs, preventing complications from immobility, like we discussed earlier on, good nutrition, preventing injury and anxiety. Parkinson's disease is a progressive degenerative disorder where there's a loss of coordination and control of involuntary movement, motor movements. This one is actually caused by a deficiency of the neurotransmitter dopamine. What are the signs and symptoms? The patient will have tremor, rigidity, and bradykinesia. Please look at page 384, figure 22.4. These are the clinical manifestations of your Parkinson's syndrome. There will be a forward tilt of the trunk. There will be reduced arm swinging, rigidity and trembling of the head, rigidity and trembling of extremities, and shuffling gaits with short steps. Right, so how do we diagnose? Medical diagnosis of Parkinson's is just based on the health history and the physical examinations. What they do is they will try to rule out other things first. They will order, bunch of tests, CAT scan and MRI, and once they rule that out, and then they, do the health history plus the manifestation of the patient, then that's how we can diagnose the Parkinson's disease. Medical treatment, please remember the red one here, your levodopa carbidopa or your Sinemet, because this is the most common that we give to the patient. So other than that, we can also give Mirapex, Requip, or Europenolol, Entacapone, Comtan, Benztropine, Cogentin, Amantadine, or your Simetrel. So I just mentioned that the Parkinson's disease, this is caused by a deficiency of dopamine. So if you if you can, think about that, Parkinson's is a deficiency of dopamine. So if you want to correct it, then what you're gonna do is either maybe the goal is to increase the dopamine level, right? So one of the medication, your levodopa carbidopa, actually is the one that is responsible. This is what we call um, inhibitors of inhibitors of preventing the breakdown of the L-DOPA by the carboxylase enzymes. So if we are actually blocking that breakdown of the L-DOPA, then it actually increases the dopamine level in the body. So the goal is to actually increase the level of the dopamine, because what's wrong with the Parkinson's disease is there's a deficiency of the dopamine. All right, nursing care. Please remember that priority is safety. Because of the impaired mobility, you're gonna see them with shuffling gait, with short steps. There will be tremor. So yes, make sure that the patient is safe. Even though they will have an impaired mobility, making sure that the patient is safe, because there's a potential for injury. Inadequate nutrition too. Just by eating alone, it's like making them so tired already. So what are those diet that could actually, or nutrition that is actually good for Parkinson's disease? think it got cut off a little. Um, all right, moving forward, your multiple sclerosis. This is a progressive degenerative disease that attacks also the myelin sheath. Um, I explained the myelin sheath earlier on the function and what could happen if there's a destruction or there's a problem with this myelin sheath. Multiple sclerosis is actually an exacerbation and remission. Okay, exacerbation, remission, exacerbation, remission. Cause is unknown, but may be caused by viral infections and autoimmune diseases. These are the signs and symptoms of your multiple sclerosis. You might have fatigue, weakness, tingling in one or more extremities, visual disturbances, problems with coordination, bowel and bladder dysfunction, spasticity, and depression. How do we diagnose multiple sclerosis? Well, this is based primarily on the symptoms, signs and symptoms of the patient. And we did talk about that this is actually a cyclic remission exacerbation. So that could be part of the process for medical diagnosis. Medical treatment is chronic and progressive nature, so that's why the goal for the treatment is actually symptomatic and supportive. However, there is some drug therapy that could actually help when there's an exacerbation, which is your adrenocorticotropic hormone or your ACTH. Corticosteroids may be used to control exacerbations, but they do not slow the progression of the disease. Amyotrophic lateral sclerosis or your ALS. This is also known as the Lou Gehrig's disease. This is a degeneration of the anterior horn cells and the corticospinal tracts. Upper and lower motor neurons are affected. Um, the cause is unknown, but it may be caused or triggered by a viral infections. So what are the signs and symptoms? There will be a weakness of upper extremities, and it's progressive. So there will be a progressive difficulty swallowing or speaking. And when it gets to that severe part, then a patient may even have respiratory failure. How do we diagnose ALS? So this is actually based again on the history and physical examination of the patient. um, the presenting manifestations. However, maybe what we can do is we can also order like EMG, that electromyography. This provides supporting evidence for impaired impulse conduction in the muscles. Again, medical treatment is actually symptomatic and supportive and preventing of the complications. Okay, myasthenia gravis is a chronic progressive disease in which a defect exists at the neuromuscular junction. This is where there's an abnormal presence of acetylcholine antibodies. Signs and symptoms, you're going to see that the patient will have weakness of the voluntary muscles, and then the patient will have fatigue. Okay, so how do we do medical diagnosis for myasthenia gravis? What we do is we actually do the injection of this medication, tensilon. It's an anticholinesterase drug, and if there's a increase or markedly improved muscle tone after we inject this medication, tensilon, within 1 minute, and then it lasts for 45 minutes, and then the signs and symptoms go back, then that is a myasthenia gravis. We can also order some blood tests, your serum test for anti-acetylcholine receptor antibody, or CAT scan and MRI to make sure and check for any tumors. Medical treatment, we can give them anticholinesterase drugs. corticosteroids, cytotoxic therapies, thymectomy, which is removal of urothymus, plasmapheresis. I did talk to you guys about that, where we remove the blood, we centrifuges or we kind of like filter it, and then we put it back, or we give it back to the patient. Mechanical ventilation, especially if it's the respiratory center that is actually now getting affected by the disorder or the disease. And then you have these other neurologic disorders, which is trigeminal neuralgia in page 393 is actually where there is a intense pain along the distribution of one of the three branches of the trigeminal nerve, which is your fifth cranial nerve. The pain will have an abrupt onset and is usually unilateral in nature, meaning just one side, lasting from seconds to a few minutes. Okay. Attacks may be triggered by injection of hot or cold liquids, chewing, shaving, or washing the face. Okay. Again, for your trigeminal neuralgia, there will be a trigger, and attacks are commonly triggered by ingestion of hot or cold liquids, chewing, shaving, or washing the face. They said cause for trigeminal neuralgia is actually unknown and undetermined. However, there's like contributing factors, which is your trauma or infection, may precipitate the characteristic pain, as may compression of the nerve by an aneurysm, artery, or tumor. Medical treatment for your trigeminal neuralgia, we can give them the dilantin, phenytoin, and carbamazepine, Tegretol. They are the most commonly used to suppress the pain episodes for trigeminal neuralgia. During the acute attack, the alcohol or phenol may be injected into the affected branch of the trigeminal nerve, with pain relief lasting from 8 to 16 months. And neurofibromatosis is also known as von Recklinghausen disease. There's a type 1 and there's type 2. These are the tumors, nerve tumors, subcutaneous nerve tumors. They are benign but may be removed to relieve compression of the nerves, or maybe even for cosmetic reasons. Your type 2 neurofibromatosis is characterized by tumors affecting the inner ear, cranial and peripheral nerves, and brain tissue. How do we treat it? Primary treatment is surgical intervention. Bell's palsy. Bell's palsy is acute paralysis of the seventh cranial nerve, which serves the face. This condition usually begins with pain behind the ear or on the face. So then the pain will continue, and then there will be paralysis of the muscles of the affected side. Okay. How do we diagnose it? Of course, we try to rule out stroke, right? Because it kind of look like it's stroke, but it's not, because half of the face is actually not moving, or if it's moving, it's like weak. So the affected eyelids or do not close, the taste is impaired, and eating may be difficult. Patient will be treated outpatient with prednisone, which is an anti-inflammatory and analgesic for the pain. And then everything else you would just want to add on, like for example, because of the affected side, where the eyes is going to be open or eyelids will not close, then you will need to give the patient some artificial tears to help with that drying of the eyes. So it's like symptomatic base, right?